Okay, so we've mentioned previously as to why it isn't so clear-cut that by performing a neurological examination or battery of neurological tests will bring about a particular will bring about proposed neurological deficits based on textbook cases or based on the fact that we can theorize that a C7 radiculopathy will then equate to a reduction in triceps reflex strength or reduction in middle finger sensation. And this is due to the fact that I mentioned before, we have an extensive functional and anatomical arrangement of the plexus designed in such a way due to the fact that we have multiple convergence and divergence pathways within the plexus and a multitude amount of nerve roots that can contribute to each branch nerves. We also said that the ascending and descending afferent pathways within the spinal cord, the concept of neuroplasticity, and the concept of the brain or motor cortex to be able to provide either an increase or a reduction in neural drive. This brings about a constant variance within neural tone. And this constant variance within neural tone or neural drive isn't specific at one point in time. So that by performing neurological tests with a particular person at a particular time of day won't bring about particular proposed neurological deficits based on our assumptions, say from a CT or MRI. This constant variance means that it's not completely reliable to perform a one-off neuro exam at one time. So based on this, we also have to understand the concept of grading nerve injuries. We know from Sutherland and Dow, graded nerve injuries based on the fact that we have 6 subtypes of injuries, and that it's clinically impossible for clinicians to differentiate a neuronemesis and an axonemesis. Within a neuronemesis, we have a full separation of the nerve and its related connective tissue compartments, that being the endoneuron, epineuron, and the perineuron. With an axonemesis, we have either damage to the axon or damage to the axon and the endoneuron, its connective tissue surrounding the actual individual axons, or damage to the endoneuron and the epineuron. And between these grades of the axonemesis and a neuronemesis is quite clinically hard to differentiate the two. Whereas within a neuropraxia, you're going to get, well, there's not going to be any neurological signs. Whereas in a neuronemesis or a grade 4 of axonemesis, or a cord lesion, for example, a central cord, posterior cord, or a anterior cord or hemicord lesion, you're more likely to get proposed increase in neurological deficits. Whereas in a neuropraxia or grade 1 axonemesis or an individual nerve root, your neurological exam may or may not bring about particular neurological deficits or positive tests that we would assume based on your understanding theory on neuroscience. So having said that, it's very important to now understand the concept of Wallerian degeneration. We know with Wallerian degeneration that proximal to the site of lesion, we have disintegration of the node of Ranvier and a sequence of degenerative immunological events which occur distally from the site of lesion towards accompanying neuromuscular interfaces. We know it's very important that to diagnose a site of neural lesion is clinically impossible. So to say that you have a carpal tunnel syndrome, and a carpal tunnel syndrome exhibited by a particular type of test, a Phelan's, reverse Phelan's, or Tenel's tap, we know that once Wallerian degeneration has occurred down to its neuromuscular junction or end plate, then the process of regeneration occurs. That process of regeneration from the periphery back to a compressive lesion at the carpal tunnel, that distance away would be roughly about 5 to 10 centimeters. We know that the axon can regenerate at 1 millimeter per day. That's getting about a prognosis of 3 months' time for complete regeneration. So if you've treated a diagnosed compressive lesion at the median nerve under the carpal tunnel, and after 3 or 4 months there's no change in symptoms, you're no longer treating a carpal tunnel syndrome. You're treating carpal tunnel syndrome with an overlay of central sensitization. By looking at if there was a C7 radiculopathy, and we know that from the end plexus, between the end plexus and the end of the periphery, or its neuromuscular interfaces, that could be a duration of about 70 centimeters to a meter, depending on different segment lengths. Now, we know that 1 millimeter, the axon can regenerate per day or an inch per month. That getting about just a 2 to 3 year time period until there's complete regeneration of the nerve and the neuromuscular interfaces. So if outside that scope of time, where your treatments aren't providing any symptomatic benefit, and say you're diagnosed with C7 in 2 or 3 years, there's no change, you have a C7 radiculopathy with an overlay of central sensitization. So these respective timeframes within where the site of lesion is brings about a particular emphasis on providing a more of a or moving away from the tissue, singular tissue and lesion diagnosis. We know that the nervous system is quite plastic, and we know how varied it can be in terms of its complexity and its function. But by giving a single entity or a single tissue diagnosis lesion isn't good enough. We know that for the concept of Wallerian degeneration, which can provide a double crush phenomenon, so having multiple sites of lesion within the nerve distribution, can also complicate or further the diagnosis. So if you're assuming a carpal tunnel syndrome, that could be a result of a C7 radiculopathy 3 or 4 years previous to. So this concept of double crush, and adding on to that the idea of by providing your treatment effects which extend outside the scope of prognosis of time in which you've treated, you have 3 potential diagnostic entities or pathologies within your original primary diagnosed lesion. So by having a carpal tunnel syndrome, which hasn't gone for 4 months, you have a carpal tunnel syndrome on top with central sensitization overlay, and that carpal tunnel syndrome being a result of a C7 radiculopathy due to the concept of double crush, you have 3 pathological entities, long-standing entities, which doesn't belong to fit in the criteria of a single anatomical diagnosis.